Okay, so having done the whole workshop, uh, one of my colleagues told me I am only a user of evidence, I don't generate evidence. So many of us may not do randomized control study, but definitely in our specialty we'll read randomized control study. So this session is like if you, for people doing, you learn what mistakes other people did. But for other people, it will be useful if you're reading a randomized control study or you're teaching your colleagues how to read a randomized control study. This may be useful. So this is what is critical appraisal? It's really questioning, reasoning, analyzing. So once we did this workshop in Muscat, and the people are like, how can we question the big shots, our teachers who are published in NEJM? They are, so we cannot go the mindset in research like that. You have to have a slight curious bent, a little cynical bent that probably what is being said is not the truth. And we are not making fun of the researchers. We have to assume they did a good, they tried their best, but they probably might have made some mistakes. Ultimately, we are responsible for the safety of our patients. So we can't say that because came in NEJM, I'm going to change my practice, or Lancet, I'm going to change my practice. Because I'm responsible for my patients, I must make sure the study was done well and it can apply to my own patients. So we should not be proudly doing, oh, everything is nonsense. But at the same time, we have to have slight cynical bent of mind when we do critical appraisal. Now, this paper also leads me to a lot of trouble. This is the one of the this is this is the most highly quoted paper in medical research. We might not have heard about this gentleman. It's a bit small. John Ioannidis. He's a professor of medicine, internal medicine, Stanford Medical College, and biostatistics and research. So he wrote this paper, which is published quite a while ago, and he has said that 80% of published medical literature is actually false. 80% of medical literature in allopathic medicine is false. So that is why we must do critical appraisal to get rid of, to find out what is junk and what is real. So that is one of the real motivations to do. So most of the papers which he analyzed in this analysis had no hypothesis. While they're doing the study, nobody written anywhere hypothesis. Many of them had a PICO question for which the study design was something else, but they had the wrong design. Many of them had significant biases in the study design which they didn't report. And many of them found no difference but decided to put spin on it, but we didn't spend some time. Even if you don't get a significant difference, one can write there was a trend toward, it appeared that in certain males this works, in blacks it works. So that is called spin. So that is wrong interpretation. Either willfully or without knowledge, we are wrongly interpreting data. So let me ask a question. Is there occupational lung disease an anesthetist? I hope there are no anesthetists here. What would you do? Study design. I have some people in my blog, like they come back in the evening, like they look like, what happened, guys? No, long theater day today. Even though you have the latest machine, some of those gases seem to escape. A cohort study, so you'll follow up a lot of anesthetists and see how many develop. So you can do that. Simplest is cross-sectional study because it's very quick. You can make out by the end of the theater day how many of them feel a little bit, woozy, like they had some strange plants. Like, I'm just joking. Why do anesthetists have occupational lung disease? So this is an etiology question. Study design will be a case control. You take some people who had that weird behavior at the end of the theater day and some who didn't have. Then it may not be at all anything to do with exposure to the anesthetic gas. Maybe they were popping some tramadol. I'm just joking. Sorry. What happens to those with occupational lung disease? Suppose you have anesthetists with occupation. What happens in the future? So the cohort study. So that's great. What is the best method to prevent occupational lung disease among anesthetists? So now this is an intervention, study design is RCT. So the first question when you're doing critical appraisal is, what was the question being asked? And then is it the correct study design? Because you can't straight away take the RCT critical appraisal tools and appraise a diagnostic study, a cohort study. Suddenly you will find that where is randomization, or these people didn't do randomization. But that was not their aim. They were just following up people to see long-term outcomes. So we should not make that mistake. Now that you have your PICO question and you have your correct study design, how do you plan your study? So this is a free website which most of you might have heard about. It's called the Equator Network, which stands for Enhancing the Quality and Transparency of Health Research. So if any of you are planning a randomized, this is a free website. If you're planning a randomized control study, you must read the guidelines called consort guidelines. It's a reporting standards, but if you're not planned properly, you can't report. When you're suddenly reading that, oh, I didn't know properly about allocation, I didn't do it, how can I report it now? So you will just leave it out. Or so if you're planning a systematic review, there's a PRISMA checklist. If you're planning any one of the observational studies, case control, cohort, cross-sectional, it is called the STROBE checklist. If you're planning diagnostic study, it is STAR D checklist. Like that, there are different study designs. This is a checklist for publication. But if you want to plan a study, you must read this. Then only you can plan very well and report very well. So even for critical appraisal, one can use the consort checklist and see. Very often when you submit to a journal with a randomized control trial, they will ask you, can you give us a consort checklist? So then you'll have to write in the checklist, in the consort randomization, and you'll say, in my manuscript, page 2, paragraph 3, randomization is mentioned. So that when it goes for peer review, they can check against everything. So this will bite you sometime there. So you must, when you're doing a critical appraisal, you should also have a look at these. If you plan well, you can report well. So well begun is half done. So if you plan well, then that is half your thing. And use the reporting guidelines to plan. So that I just already mentioned. Now, how to do critical appraisal? Now, you may want to become an expert on that. Then this is really good. When we were studying, the JAMA, or the Journal of American Medical Association, had a large series of articles on how to critique a journal, published from where Dr. Srikanth is, McMaster University. Some big names like Gordon Guyat and other people, there are some big dadas in this epidemiology. So they wrote a series of articles. After some time, they published it as a book. This book is available on all Indian platforms. I mean, Amazon, whatever. You can buy the whole book. You can get the soft copy of the book. Currently, it's the 3rd edition. This user's guide will give you an example of an RCT. It will take you through the questions of critical appraisal and give you a longer explanation. So you don't have to understand much science. At the end of it, you'll understand all about an RCT, how they critique. Now in India, like we have pathology book, then you have baby robins, now you have fetal robins, now some of they want infant robins, like so the neonatal robin, because that's all they want to spend time on. So the baby robins version of the user's guide is this essentials of that. So this will just give you the questions and a short explanation, which if you already have a good idea of RCT, this book is really useful. But if you really want to understand in depth, then this book is useful. So mostly I advise, in your department, if you have one copy in your department library, then it's fine. So anybody can take and use it. So these are excellent books for critical appraisal. So it's user's guides, it's called. No, for all designs, every design. So all the designs are mentioned in this, all these designs and more are available in this guidelines. Now, some people find it a bit laborious to sit and read all that and make that slides. Now, the same user's guide has not been updated for a while now. In Oxford Evidence-Based Medicine Center, they have taken those same things from this previous things and made an online form. It's called CASP, Critical Appraisal Skills Program. So you can Google now also CASP, Critical Appraisal. You will get 10 or 15 different critical appraisal forms for different study designs. You can fill it up online also, and then your critical appraisal is done. For each question, they'll give you an explanation. What is this? Because English may be difficult. What do they mean by that question? So once you read the article, you can answer that question. At the end of it, critical appraisal done. So now we are increasingly using this CASP checklist. So just Google CASP checklist. You'll get 20 different checklists. You can choose one to fill online or download and fill and use it for your presentations. So this CASP checklist is really useful. So why do we do critical appraisal? Separating junk from jewels. So wheat from chaff, different ways of saying the same thing. Second thing is, okay, we found a study with a very good relative risk, confidence interval, very good. Does that mean anything? Like, is it a minimal clinically important difference or not? Now you all understand MCD, minimal clinically important difference. Okay, this study found a minimal clinically important difference in Alaska. I'm sitting here in Jammu and Kashmir. Can I use the same? Will the results be same from Alaska? Will I get the same results here in India? I may not get. So the third question to ask yourself is, yeah, it's really good. The MCD was a very good study. I may not get the same results in Jammu and Kashmir. So I should not use the results. The good study, well done, good, beautiful results, but for some reason, I'm not comfortable to use the same results in India. So that's the three things we are going to do in critical appraisal. Is it a junk study? If it's not a junk study, what are the results? If the results fulfill my minimum clinically important difference. Third question is, can I use it in my patients? That may vary from your clinic to his clinic. So each one has to answer differently. So let's give it a try. In people with mild asthma, currently we have asthma only once or twice a year. I have asthma, so I have a salbutamol inhaler. Whenever I feel something, I'll just take a little puff. But now the question is, maybe I should have a little bit of steroid also, intermittently, along with that salbutamol, little steroid, so that it will reduce the inflammation. So the question was asked in people with mild asthma, should we get steroid plus salbutamol or not? So this is a therapy question, because I'm trying out a new treatment. And the study design should obviously be a randomized control study, because I want to try out a new treatment. Now, I'll just give you 30 seconds to 1 minute. Can you open this article? You can Google it. If you're on CMC Wi-Fi, you can download this article. Control trial of budesonide formoterol as needed for mild asthma. It's on your phone. If you have the CMC Wi-Fi, you can download the full PDF. If you're doing your own Wi-Fi, NEJM won't allow you to download the whole. So you have to use the CMC, the Wi-Fi, that username, password. You can download this article, and once you download that, if you've done it quickly, you can also download CASP RCT. So this website on the screen I'm showing you, if I just simply Google CASP, I came to CASP checklist. So now I'm in the CASP UK website, and these are it's a free website, so you can download these for free legally. And here the first one on the CASP website is the CASP RCT form. So I can do a PDF version. Print and fill means you can fill it up online and then save it and then just directly print out. It will have a beautifully formatted one. Or I can take the Word version. So I'm just going to show the CASP PDF form, but I'm using that one. So you need to have, when you're doing critical appraisal, have the article ready, have the checklist ready, so that every time you're doing that and that. So this is one, and the article that you need to get is this one. So can make it big. So you need to have this article, control trial of budesonide formoterol as needed for mild asthma. BEASLEY, Beasley is the name of the author. You may find many studies like that, but this particular one is in New England Journal of Medicine, and the author is Beasley. It was published in 2019. So these are the words to use. Okay, so if you see the CASP checklist, you will find that there are 3 sections, the same sections which I mentioned a little while earlier. The first section is the study valid? Valid is an English word for truth. We don't know the truth, but we believe that if the study was done properly, like you say, if you're doing cooking, you have good quality ingredients and you follow the steps, then most likely you may get the correct dish. There's no guarantee of that. But here we say that if they followed randomization, allocation, blinding, laws to follow little bit, they published all the results, then the results can be believable. So we have to take that little faith that if they did everything correctly, then the results are believable. So validity is mostly found in which section? Introduction, methods, results, discussion, conclusion. Discussion, any other choices? Methods, anybody else? Right, method section, because there only you know how they did randomization. And if you see, most of us, when you see a new article, our eyes will go not to the method section, but to the abstract. If you have less time, not at all the abstract, only the conclusion of the abstract, like, oh, this doesn't work. Okay, that's it. Why should I read the whole article? But critical appraisal is that painful part where you have to read the method section. So don't read it when you're in a hurry and you have 2 minutes to read it and then you'll just not read it. So it should be an exercise worth doing. So if you're doing an article for critical appraisal, very important, choose something in your own area of interest and some article which attracts you, like, hey, I want to know the results for this trial. Otherwise, if you're just doing an exercise of critical appraisal, sometimes it becomes boring. So what I make the PGs in my department do is tell a clinical story of a patient you saw, and that story led you to this article. Like I told you a story, a hook. I have asthma, and I want to know, instead of just taking salbutamol, whether this will be interesting. So then maybe some of you are interested to know this article, but some of you may switch off. This is totally not my area. So you must actually give a hook when you're doing critical appraisal. Talk about a patient story that led you to this article. And when you finish the critical appraisal, you must end with saying, what are you going to recommend for your patient? So begin with the patient story and end your critical appraisal with the patient story. So the first question in CASP, did the trial address a clearly focused issue? Now you may wonder, what is that? I can't understand what is a clearly focused issue. And they've given you a hint, PICO. Have they talked about PICO? Now you have got the article with you in front of you. Now you must look at the method section. In the method section of every RCT, there will be one PICO. So I'll give you 15 seconds to look at the article if you have it open. And for those of you who don't have the article open, you'll find that under the patient section, they had 18 to 75 years of age. The doctor had to diagnose asthma. They were on short-acting beta agonists as a sole therapy. I mean, this pulmonologist loves strange mnemonics, Saba, Lama, you think that. But, I mean, and they had to have used it on at least 2 occasions in the last 4 weeks. And there was no minimum requirement and something. More important than the inclusion criteria, you must look at the exclusion criteria. Can somebody tell me why exclusion criteria is so important? Because they want a homogeneous population in the clinical trial. Why? From what Dr. Kant taught us? To reduce variability, to reduce noise. Less variability, studies become better. But they've excluded people who smoked a lot. Can there be an asthmatic who smoked? There can be so many asthmatic who smoked. Will the results of this particular study apply to that person? No, because they've been excluded from the study. So usually, when you read this, it was very important, they'll give you about 20 exclusion criteria in the paper. All modern studies, you can go and find the original protocol, because all studies have to be registered in India with CTRI, or in this is clinicaltrials.gov, or you can find it. When you read the whole protocol, you'll be surprised. There'll be 20 more exclusion criteria which they didn't tell you here. Then in real life, it's very difficult to find one asthmatic human being who fulfills any criteria, because most people were excluded from the study. So you must spend a little bit of time reading that exclusion criteria. Now, obviously, if somebody is allergic to the drug, then they can't be given. Then sometimes they'll exclude pregnant women. But is it a good idea to exclude pregnant women? How many think we should exclude pregnant women? Now nobody's saying anything. But the thing is, tomorrow a pregnant lady comes, how will you ever know what to give her? So unless this is a class X drug or class D drug in pregnancy, you should think about, unless, I mean, it should not do harm to the mother or baby. Otherwise, we should include. Should we do children in such a study? Any pediatricians? Yeah, unless you include children, you will be giving adult medicine to pediatrics because it's unethical to do trials on them. So you should include them, but an extra step. Info, patient's consent, child assent, and the IRB will be very worried. What are you doing on this child? So we have to include as many people as possible. That is what Dr. Kant was talking about, pragmatic trials. Pragmatic trials will not have too many exclusion criteria. And if you're interested in doing critical appraisal of pragmatic trials, anybody remember the website he mentioned? Precis, Precis, Precis. You can Google Precis. They'll give an online tool that is for an RCT to see was it a pragmatic. Pragmatic means real life. Hardly any exclusion. Anybody who walks into your OPD with asthma, I can include. I mean, the one exclusion will be have allergic previous anaphylaxis to this drug, then that is not pragmatic. But other than that, generally they should have included everybody. So if one of the things you can do in your department critical appraisal is try the Precis rule and see how pragmatic was this real trial. No, I'm saying, why could they have not included all people? Most trials will say 18 to 75. Why not 80-year-old asthmatic? You know why they don't include older people? They'll have more side effects. Then the people will report, oh, that study, lot of side effects, don't give the drug. So the farm, nobody wants to have all those bad things in their trial. But in real life, a 76-year-old asthmatic may come to you. Then we have to give based on what younger people's study was. So really, we should not exclude many people. That's the whole thing. The intervention were 3 types of intervention if you read the study. One was budesonide maintenance plus salbutamol whenever needed. So this is one intervention. The second one was budesonide formoterol, which is a steroid plus long-acting beta agonist. One inhalation as needed. So this is the main intervention they're looking at. Steroid plus beta agonist given whenever required. And the comparator is what I was using currently, which is salbutamol, or it's called albuterol in the West, whenever needed. So I'm going about, I don't have any asthma. Whenever I feel testitis, I take 2 salbutamol. That's my current treatment. They're asking is, why can't I, instead of just steroid, instead of salbutamol alone, can I just give a steroid plus a long-acting salbutamol whenever required? Some other people said, why don't you give a long-term steroid inhaler plus whenever needed steroid? So there are a 3-arm trial. Extra instructions, very important. Whenever they include people in a trial, they'll give so many things, training for the people, this and that. Unless you read that carefully, you won't get the same results in your practice. Because in real life, you won't give 2 days of asthma instruction. Nurse won't come 2 days to your home to check your asthma technique and all. So always read the instructions given to the patients. So here they had an asthma action plan. They had to log down all their asthma whenever they worsened. They had to record steroid usage. The inhaler which they gave them in the West had an electronic component. Whenever it was pressed, the PI will know that the doctor has used the patient has used the medicine. But in India, we may not be able to afford that. So how do we record patient compliance? How much you used? Okay, on the inhaler, it will say starting off at 180. If you press once, it will become 179. Again, as Dr. Kant said, the doctor has told me, just do some this. Oh, doctor, I used all this. Show me the pill. Okay, just take the pills out and go and show. So this we must be careful how they did. So they recorded compliance by doing this electronic method. Even that they could have, how do you know that they put it in the mouth? So these are questions to ask yourself. The reason is something called the Hawthorne effect. That is, if like for example, heart failure studies, you'll find the normal mortality of heart failure is about 50% in 1 year. But in all heart failure trials, the mortality will be about 10%. That's mainly because once you enter a trial, one cardiologist will see you every 2 days. Some nurse will call you every 3 days. Every week you're coming to see the doctor. So your compliance with medicine becomes better. All sorts of things happen. So under observation, your behavior of the patient and the doctor changes. So you should be a little bit careful when the intervention is not exactly what you may do in your clinic. They had 7 trial visits over 52 weeks. Week 6, 12, going on up to week 52. Then you must ask yourself, in real life, will this happen? Will I ask my asthma patient to come 7 times in 1 year? Anyway, they're doing it for the sake of safety or whatever, but you must always keep this question in mind. Always in a randomized control study, can patients withdraw themselves? Yes, for no reason also. I don't want to be part of your study. They may give 2 kinds of withdrawal. Doctor, till now, whatever data I had, you withdraw. I mean, you can keep it, but from now on, I don't want to be part of your study. They can even say, for no reason, I don't want any of my data in the study. That's bad luck. I mean, that means they are not comfortable with something. So there always a withdrawal criteria. If the patient is doing badly for safety, you have to withdraw them. You can't say, no, my study will be spoiled. intention to treat gone. No, the patient safety is always first. So there always has to be a withdrawal clause from the study. Unstable asthma, any combination, or the primary physician was uncomfortable. So always there'll be a clause when the doctor is not comfortable, because ultimately you're doing a multi-center study. You may never see the patient, but the doctor in the clinic who's managing the patient daily, he has to answer like, why I enrolled you, and he has to be responsible. So even if he's uncomfortable, this patient can be withdrawn. So then what is the outcome? So remember, we are going over PICO. The primary outcome measure was the annualized rate of asthma exacerbation per patient. And they have given the definition of one asthma worsening. So that means you have come to the emergency department, you were given steroids, and the dose of your salbutamol increased. So always you must be careful. What was the definition of the outcome? Was it an outcome 1? Was it a mean number? Was it a continuous value? So there are so many different ways Dr. Kant talked about outcome measures being done. Was it a count? Was it the average number? Count per year? Count per persons per year? So there are different ways of expressing the outcome. So the secondary outcomes, there were a number of them. Number of exacerbation, time to first exacerbation, number of severe exacerbations, asthma quality of life by the ACQ questionnaire, and a whole host of other secondary outcomes. And for them, they put adverse events in the end. But remember, nowadays, modern trials will ask you what's your primary benefit outcome and what is your primary harm outcome. And that has to be reported upfront. It can't be somewhere hidden somewhere. So outcomes have to be done. So that's the first question. So you can see that we are spending so much time on these questions. Later on, the questions will be faster. But this is where really you must spend the time looking at the question carefully. Was the assignment of patients to treatment randomized? So the hint question is, how did they do randomization? Was allocation sequence concealed? Can somebody read the paper and tell me where it's mentioned? Remember, if you are submitting a paper like this, you'll have to say on page 3, paragraph 2, line 3, this is where randomization method has been done. And this is how allocation has been concealed. Can anybody find that in the article? Okay, can you read the sentence? Anybody? No, how was randomization done?
Randomization was stratified according to country and was performed with the use of a computer-generated sequence with a block size of 9.
And allocation concealment?
An electronic clinical record system concealed the patient's treatment assignments until the time of randomization.
So this is clearly given. How they did the randomization? Was there stratified? Was there block? Currently, as Sir said, nobody will tell you the block size, because I can make out the first 5 patients and the next 4 I can sort of guess what they're going to get into. Nowadays it's variable block so that nobody can game the system. But they have given a block size of 9, and this is how they have done. Yeah. So to give a comment, and in this you have to write 3 things: yes, can't tell, or no. Yesterday I showed you in the systematic review the green, yellow, and red boxes when you're doing critical appraisal, the risk of bias. Suppose this paragraph was not there. You write to the author, he doesn't reply. Are you going to say randomization was done, was not done, or can't tell? Can't tell. So sometimes when you're doing critical appraisal and you're doing systematic review, you'll find yellow. Naturally, we think green is good, yellow is not so good, and red is bad. Red is when that guy says, I didn't do randomization. Yellow is when he doesn't reply to you at all. It doesn't mean that yellow is any better than red. So that's something to be careful about when you're doing this critical appraisal. Next question. Were all the patients who entered the trial properly accounted for at its conclusion? Now that may sound like, what is this? So much of English. Hint. Was the trial stopped early? So this is a hint I always tell. If you have the PDF, you can put Control F on your laptop and you can put the search words. You put Control F on small, you can search in the PDF for words. You can put stopped early. then no word exists, and you can say at least the paper doesn't mention anywhere stopped early. Other people say, I cannot read the whole method section to see stopped early. So sometimes I can't read 10 pages to find randomization. Okay, search for the word randomization, you will go straight to that particular word. If the trial was not stopped early, were the patients analyzed in the groups to which they were randomized? So a question. What is this figure called? Anybody? Consort figure. Now, this you can see figure S1. Usually the S1 means supplement 1. So all the journals nowadays will give a maximum limit, 3 figures and 2 tables, or 2 figures and 3 tables. Now, see, I want to put so many figures. You know, we all did MD thesis, we have 20 tables and 20 figures. So it's a big heartache, like which to give, which not to give. So these people have decided the consort figure is mandatory in every publication. It's usually figure 1. But for the sake of their wanting to put figures, they put it as a supplementary. So when you're doing critical appraisal, you must go and find the supplementary online and take out the figure. So you can see that they assess 690 people for eligibility and they randomize 675. Only 15 people were excluded. Does that say anything to you? Out of 690 whom they screened, they could include 680. That means even though they had a lot of exclusion criteria, most people could be included. This is not validity. This is called generalizability. Okay, that means most people with mild asthma who come in my clinic also, I can try this therapy out on them. That figure often is not given. Many consort figures will just begin with the number of people randomized. They won't tell you how many people they screened potentially for that. When you find a big difference between the screened and the number randomized, it gives you a hint that, hey, this is not so generalizable to other populations. They had to screen 10,000 people to get 600 eligible. That means they had such stringent inclusion exclusion that most normal human beings, this results won't apply to. You understand what I'm getting at? So that is an important number. The question, however, was, were the patients analyzed in the groups to which they were randomized? So I just explained that. They randomized, let us just take one group. The first group, this is salbutamol PRN, albuterol, ALB's albuterol or salbutamol PRN. They randomized 226 people to that arm. Just follow this number for a second on the screen. On follow-up, 5 people were lost to follow-up. 64 people discontinued treatment. 1 provided no reason. 37 people had treatment failure and had to be withdrawn. If you add up all the number of people here, then they should tell you that analyzed, there were 226 people who were randomized there. The number who were analyzed in intention to treat should be same. 226 should be 226. Here they have said we analyzed only 223. 3 subjects we deemed ineligible. So always be careful. NEJM will say this is intention to treat. But even then, they have not followed the strict intention to treat guideline. That is, everybody should be included. So then your job when you're answering this question, were the patients analyzed in the groups to which they were randomized? You must actually sit and do this maths. Oh, there were 227 people here. If I minus all the number of people who are discontinued, will all the number add up to 227? And you'll be surprised in so many journal articles, there'll be 227 here, but suddenly on the way, if you add up the numbers are not adding up. Because they didn't keep a good track of their data, what happened to patient, where did they go, where did they come, it won't work. Okay, so why is this important? And I'll just give this example. Oops. I randomized 1,000 patients to each arm, and 10 people were lost to follow up. Here 20 people were lost to follow up. What should the denominator be? 990 or should it be 1,000? intention to treat, it should be 1000. Here also it should be 1000. Suppose in this arm 120 people died. In this arm only 20 people died. This should be the results of my study. But what happened to these 10 people? What happened to those 20 people? I don't know. The intention to treat generally assumes that they didn't die. This is death. So this is how many percentage? 12%. This is 20%. Correct? Sorry, 2%. What is the worst case scenario? All those who lost to follow up died. I'll tell you two worst case scenarios. So let us add that. Suppose we add 10 to this, what will happen? Plus 10 will become 130 or 13%. Here if we add 20, 4%. Does it change the direction of the effect? No. So you will say this loss to follow up did not affect the outcome. What is the real worst case scenario? If this was a new treatment or the intervention, and this is the comparator arm, or let's put it the other way. This is the intervention and this is the control arm. The real worst case scenario for a clinical trialist is if none of these people died, but only all the people who are lost to follow up on your new treatment died. That is the real worst case scenario. So now you put 4% here, and here we keep it as 12%. Okay, so whatever sensitivity analysis we do, worst case analysis we do, the loss to follow up did not make a difference. So when will it make a difference? Suppose this number was 8 and this number was 2. Do you think the loss to follow up will make a difference? There were 10 lost to follow up, 20 lost to follow up. Will it make a difference? Hey, you will say this is 0.8%. This is 0.2%. Very good. The p-value is significant. The new treatment is great. But if you do a worst case scenario and you add these people here, suddenly there are more deaths there than here. So even though the loss to follow up is less, almost 1% only, if the percentage of outcomes are small, even small loss to follow up can affect your results. So even though we have a ballpark figure, 1% loss to follow up, 2% loss to follow up, it all depends on the number of people who have the outcome. Yeah. So this one question. The second thing to learn in this slide is, what is the percentage loss to follow up? Can you tell me in this group? 226 were randomized, 3 not eligible, 5 lost to follow up, 64 discontinued. Treatment failure is an outcome. So actually if you added up 64 plus 5 plus 3, it's almost about 70 people were lost to follow up or did not complete the trial. There's a large number of people for whom the outcome was not clearly known at the end. So you have to actually sit and do these calculations. But the question is slightly different. Were the patients analyzed in the group to which they were randomized? So I'm going to ask you, listen carefully to this. Suppose somebody was randomized to salbutamol alone. And after going out of the clinic, he got severe asthma and he got irritated. Hey, I thought I'll get a free steroid inhaler. So he goes to the shop outside and buys a steroid inhaler. Then shall I put him into this group? How many say yes? Technically, he has followed this group now. He's taking steroid every day and taking the salbutamol whenever. Should we randomize? Should we put him into that group? This is a crossover. No, we are putting 10% crossover and from this group to that group. So what should I do with that such a person? He was not very happy with this group. Very quickly he went off and started doing this. What will I count him as? Anybody? He is a failure in this arm because he got out of this arm. So he will remain in the denominator. 226, he'll remain here. He will be counted as a failure in this arm. You should not say he did this and put him here. Many people do that. That is the crossover. That's why I asked the question, were they analyzed in the group to which they were randomized? The randomization also occurs. Once you're randomized to that arm, for the PI especially, till the trial is published and for eternity after that, that guy will always be in that arm to which he was randomized, whatever his behavior. That's why people often have a long run-in period. Run-in period is the beginning from assessing eligibility to randomize, 2 weeks of welcoming them, giving them food, checking, is he coming regularly? If this guy is not even coming the first 2 weeks, he won't come definitely for the next 1 year. So don't randomize him. So these are all, you'll find in the exclusion criteria, people who are living on the street, IV drug abusers, chronic ethanol users, or those whom the PI think the drug may not work. Who are those? Some vagabond urchin. This fellow won't come, and after randomization, I'll be cursed with him, so exclude him. But the problem in real life, you will find people with alcohol, IV drug abuse coming to your clinic, and the drug will never work as well because they have kicked them out of the trial even before randomization, right? Okay, next question. Yep. Yes.
But in that follow-up, subject found to be not eligible in circulatory, what may be the reason?
When you have multi-center trial, junior doctor was on duty on weekend. He never read all the exclusion criteria. Before you came, actually truth. By Monday when you come out, randomized and started. Oh man, is my guy smoke 40 packs of cigarette? Did you not see? Sorry, sir. But once it is randomized, you're stuck with that person. So when you have multi-center trials, actually they'll have investigator meet, and every center will have one more session with all the people in the study. This is your role, responsibility. Despite all that, these things happen. This is pharma-initiated trial. They're very strict. Investigator-initiated academic center trials, it will be quite more terrible things happen, but people may not report it. These people are required by law to report it because it's all legally done and people can go and check. Auditors will go to pharma company and audit all the data. They will very rarely come to CMC and say, in our city, show me all your data. So they may come one fine day, but we get away with many of these things. They are forced to report all that. Were the patients, healthcare workers, and study personnel blind to treatment? Anybody can tell me? Now, put Control F and see blind. Remember, blind is a bad word in India. People are blinded and tortured. So masking. So you may find the word. Is there anywhere in the article blind or mask? No. See the method section. So that's the whole thing. When the question comes, read the methods. Either they'll say open labeled. That means everybody knew everything. Or they'll say the patient was blinded. The physician was blinded. Says here, patients, investigators, and the statistician were all aware of the treatment group assignments. Correct? Found that word? This is from the article only I've taken. So this means what? Nobody was blinded. Suppose, okay, just listen carefully. If the outcome was death, would you say this is a badly done study? No, because it doesn't matter whether you knew or didn't know. Here, what's the outcome? Asthma exacerbation. So if the patient knows and he feels sorry for the PI, I had some asthma, I won't report it. This is only mild, I don't have to tell anybody. So you can see subconsciously what may happen. These are called soft outcomes. Outcomes where the investigator or the patient has to report the outcome and they know what treatment group they get. Either they may get irritated with you and say, I had exacerbation, or they'll feel sorry for you and not report exacerbation. Or the PI knows and he's calling the patient, sir, how are you feeling? I had exacerbation. No, that may be some cough and cold, rainy weather, like that is not asthma. So see, soft outcomes, not consciously we don't cheat, but subconsciously. So whenever you have outcomes which are not, let's say a biochemical value, sodium, potassium, creatinine, which somebody can fudge, then those are called hard outcomes, which nobody can generally fudge. Mortality. Whenever you have soft outcomes, you can't really blind who got salbutamol, who got 2 puffs and 3. The person who must be blinded is the outcome assessor. So in all open label trials, you must ensure that the outcome assessor is blinded. That is a real catch. When the outcome assessor is not blinded and the outcome is considered something which people can guess or not guess, then it's a big trouble for you, right? So that's an important thing. So how can emergency department visit and admission be a problem? So many people are very sick, sit at home, but some people will land up to hospital with mild symptoms. In many cardiovascular trials, they'll say admission for heart failure. But I have seen in our casualty department, some fellows gasping, cardiologist gives lots of Lasix and say, go home. Another cardiologist will say, no, admit. Especially if they know they're on a trial, then they may be subconsciously biased towards admitting or not admitting. He's on the trial intervention drug. No, high dose Lasix and go home, like, because I don't want to spoil my study by admitting all these people. I mean, I'm not saying consciously people do, but subconsciously this may happen. Is that okay about blinding? So this is an important question about blinding. Okay, the next one. Were the groups similar at the start of the trial? This is a hint. Look at the age, sex, social class, etc. Where will you find this information? So can you all see table 1 of the article? Figure 1 is always the consort figure. Table 1 is always baseline characteristics. Did you all see that table? Now, it will never be 100%, at 33.4, 33.4. If you randomize large cardiovascular, those 20,000 trials, each arm 20,000, in that case, you'll find that down to the decimal point, everything is same. But in small trials, if you find everything is correctly the same, then you have to be a little worried, like, oh, did they do some magic? The baseline characteristics. Were the age roughly the same? 35, 34, 36. Now let me ask somebody, is 34.9 same as 36? No, it's different by 1 year. The question you must ask yourself in RCT is, so this is important, would that 1 year difference make an outcome difference to asthma exacerbation? Just because one group was 1 year on average younger, it may not have made a difference to the outcome of asthma. So always when you look at baseline characteristics, in many studies now they'll put a p-value. That is highly dangerous, not recommended, but many journals will insist on putting p-value on baseline. P-value is only when you're hypothesis testing. I was not testing whether there's a difference in age between the 3 groups. That was not my hypothesis. But journals will insist. If you have 20 baseline characteristics, let me see how many of you are picked up from p-value. What is the chance that one of them will be different using a p-value? So when you have 20 baseline characteristics, 1 out of 20 is 0.05, 5%. So if you put a p-value, even if you do fantastic randomization, definitely 1 out of the 20 will show a difference in p-value. Then you are sunk, oh, the randomization failed. So never do that. What should you do? Look at every single one of them in the light of, will this make a difference to my outcome? There may be 2% difference in diabetes. That's all right, but it won't affect asthma exacerbation. So I'm not worried. So it's a clinical judgment made by you, not by p-value, right? So don't ever go by p-value. Don't look at anything except any of these will make a difference to my outcome. Somebody will say, eosinophil count is very important for asthmatics. Okay, then it's 3,000, 300, 300, 300. That's very similar. Or the pheno, or whatever. If you're a pulmonologist, you may look at many things. And you must know if those important variables are different or not. This is the magic of randomization. If you randomize more than 200, 300 people, this will work. Most of our PG thesis, we do about 50, 60 in every arm. Then you will not get this beautiful thing. That's not because the randomization failed, but because that is a bad luck. Then you have to adjust for it later on. Question number 6. Aside for the experimental intervention, were the groups treated equally? The study was done for how many weeks? So from the beginning of randomization till the end, how many weeks were there? 52 weeks. If it was a blinded study, nobody knows who got what. So why would the PI give extra love and affection to one arm and no love to the other arm? He won't know who got. But here, what may happen is, the PI wants this arm to work. So he may give them gym membership, extra pulmonary physiology, smoking cessation, extra treatment. I'm making fun, but this actually happens. So in an open label trial, it always worry whether the arm which the PI wanted got extra love. They were told to come weekly, and the other arm was told you come whenever you feel like. So these are subtle things where you will find that one arm was told to come very regularly, one arm was given extra gym membership, dietary care, and blah, 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 air filter in the house to avoid allergens and all. So these things happen, but very rarely people will report it. Sometimes you can find out this in the limitation section. There'll be one limitations part at the end of that discussion. You can go there and read, some things happen like this, which you may not know otherwise. But so the answer to this question, other than the treatments, were they treated differently? You have to read the article to find out. So these are also called co-interventions. What are co-interventions? Extra treatments other than what was given. So in a blinded study, generally this is not important. In open label study, these co-interventions become a big deal. Okay. Now, I thought some of you may look at the limitation section. In the limitation is given, the limitation of the current trial include the occurrence of more frequent scheduled clinic visits than would be expected in routine clinical practice, and the patient awareness of the use of electronic monitor of inhaler use. So patients knew that if I come up every week for follow-up and I have not done enough inhaler, that I'll be caught. So they might have done something to please the physician. Okay, now we have answered all the initial set of questions. I told you critical appraisal has 3 parts. Is the study valid? If it is valid, what are the results? If the results fit my minimal clinically important difference, then I can ask, should I change my practice? So we have finished asking the first set of questions, which is the majority of critical appraisal. Is the study valid? So how many of you will say the study is well done? Put up your hand. Credible? So to give me an opinion, shall I look at the results or shall I not look at the results? Very bad? You actually have to make up, because all of you are reading the RCTs to change your own practices every day. You have to make up your mind. So why should you make up your mind? This is a nice mnemonic, garbage in, garbage out. So either I can decide it's a garbage study. If you think it's a garbage study, don't look at the results. Why? Usually garbage studies have fantastic results. I'll repeat that. Garbage studies have fantastic results, which everybody will like. When you see fantastic results, you will forget that no randomization, no allocation, no blinding. Oh, the study is great, let me change my practice. So always make the correct step of reading the methods first and then deciding to look at the results. Randomization was okay? Tick. Yep. Allocation okay? Baseline equa? Loss to follow up? Ooh, there was a lot of loss to follow up. Blinding? Important outcomes that you could think of which they didn't measure? They seem to cover most important outcomes. So, okay, I won't give it a 10 on 10. I'll say, okay, so maybe some 4 or 5 of. If I give a fail mark, I won't look at the results. Okay, this is not a useful paper. I don't want to see the results. But you'll never get a perfect study. And if you yourself do a study, it's so difficult to do a study. So it's not fair to just, shoot them. We're saying the study has a bias. The author is not biased, bad man, idiot, fool. No. The study had some biases or potential biases. So in fact, now in Cochrane, they don't say the study is biased. There's a risk of bias. We don't really want to be politically bad and say he is biased or she is biased. Because if you say your study is biased, indirectly you're saying I'm a biased person. So there's a risk of bias in the study. Okay, the next question is this. How large was the treatment effect? For the treatment effect, should I look at the primary outcome, secondary outcome, tertiary outcomes? The primary outcome. So the decision to use the treatment is always based on the primary outcome. Can somebody look at the results and tell me what is the primary outcome? What is the difference in the 3 arms? What was the outcome measured? Is it the primary outcome clearly specified? What results were found for each outcome? Can somebody tell me the primary outcome? Asthma patients.
Asthma exacerbation rate in glucometer was lower than that in albuterol group.
What are the numbers?
Absolute rate per patient per year 0.195 versus 0.4. Relative rate of 0.49, 95% confidence interval 0.33 to 0.72.
So remember, now this is a strange 3-arm trial. If I have 3 arms, what all comparison I can do? A versus B, A versus C, B versus C. For each one, they must report relative risk odds ratio. Since I'm doing multiple comparisons, I must decide whether I have done statistical adjustment for multiple comparisons. Many trials are very smart. No adjustment was done for multiple comparisons. Putting up your hands, okay, I'm guilty. Most 99.9% won't read the small asterisk in the bottom of the table which says no adjustment was made. And people won't realize that there is something called being careful for multiple comparisons, and they just assume that this is the correct odds ratio. So now that you are aware of it, you must say, hey, they did multiple comparisons, did they adjust for that? Anyway, so the most important thing was the primary outcome. Can somebody interpret this for me? 0.49. There were 0.195 exacerbations per patient per year in budesonide formoterol as needed, compared to 0.4 exacerbations per year in albuterol. What does 0.49 mean? Protection, harm, how much protection? So if it's a relative risk of 1 means no difference. Compared to 1.59 is 0.51 less. So you can say 51% relative protection. What is the confidence interval of that 0.49? 33 to 0.72. So best case scenario is 67% protection. Worst case scenario, 28% protection. So it is less than 1. So you're happy and saying that it seems to work. 0.175 in the budesonide maintenance group versus albuterol. So this is A versus B, this is A versus C. And if you compare this budesonide formoterol versus, budesonide maintenance versus albuterol, there is no difference. Why? Even though RR 1.12 means 12% increase, but the confidence interval includes 0.7, which is 30% protection. 1.79 means 79% worsening. So that, how can it be better and worse? So we say, hands up, there's no difference. That's the way we interpret it. So the same thing can be put as a figure, and we must try to understand the figure because some people like figures rather than looking at. So this is the albuterol alone group. So the concentrate on the middle figure, albuterol alone group. This one, budesonide formoterol group, budesonide maintenance group. So they have given you the comparisons across these different groups. So a figure is worth 1,000 words. So nowadays, when you submit to a journal, they'll ask, can you give one slide to us with everything, all information on one slide? Because nowadays, immediately Twitter, all these groups will take it and immediately it will be published. Suddenly in the news, they'll say, new drug finds this, and they'll put up that one slide. So everybody on their blogs will use this one picture. So it's your advantage to supply the journal that one picture which you want to tell. So this probably will be the picture they want to tell. So making sense of this. Some people hate relative risk, odds ratio, There were 23 exacerbations in the albuterol group. There were 9.3% exacerbations in the budesonide group, and 4% in the budesonide plus formoterol group. I just simply made it as percentages. How does this help us? For somebody who doesn't like relative risk, odds ratio, how does it help? Anybody? Absolute risk, somebody said. What is the difference between albuterol alone versus budesonide formoterol? Absolute risk difference, 10 minus 4, 6%. Relative risk is 4 by 10, so 40%. So it sounds better. So a pharma rep will always, nothing against pharma, they'll say 40% reduction. But the actual benefit to a patient is only 6%. So we as critical appraisers must not use relative risk. We must use absolute risk reduction. So we have this absolute risk difference between A and B is 10.2 minus 9 is very small, 0.9. But 10.2 minus 4.1, we get roughly 6%. This is called absolute risk reduction. So always in your paper, critical appraisal, tell your PGs, please tell us the absolute risk reduction. The next thing, how do you tell a patient absolute risk reduction 6%? Doctor, what does that mean? I also can't understand that. All right. If I treat 100 patients with the second drug as compared to albuterol, if I treat 100 patients with budesonide formoterol, how many will benefit? No. That's called the number needed to treat. So how does one get this number needed to treat? Number needed to treat in simple English is, if I treat 100 patients with this new drug as compared to albuterol, how many will benefit? That's the simple English explanation. How do you calculate number needed to treat? 100 divided by the absolute risk difference. Absolute risk difference is 6%. Does everybody understand how we got 6%? Yes? That is 10.2 minus 4.1. So 10 minus 4 is 6. So 100 divided by 6 is roughly 16. So for every 16 people we treat with albuterol, there will be one less severe asthma exacerbations over 1 year. Yeah, that is the explanation of number needed to treat. That patients also can understand. Yes? If you treat 16 people with budesonide formoterol as compared to albuterol, you will have one less exacerbation. Correct? That is number needed to treat. What does this mean? Okay, we'll come back to that. So I've given you, we have discussed the explanation. The next question, how precise was the estimate of the treatment effect? Hint, what are the confidence intervals? So what are the confidence intervals for the primary outcome? This picture here, 0.49. Confidence interval is 0.33 to 0.72. Is it very narrow? Is it very wide? There's no magic wide and narrow. Suppose it was 0.1 to 0.9. Is that narrow or wide? Wide. If it was 0.48 to 0.5, narrow. So this is somewhere in between 0.3 to 0.72. So you have to make your decision. First, have they reported confidence interval? Very often people don't report confidence interval. Why? Why won't people report confidence interval? You can't say we couldn't mathematically calculate because now all computers will give you, even Excel spreadsheet will give you. Either it was very wide or it crossed 1. More often it crossed 1 and they don't want to tell you that story. So always they must report. So whenever you have your students publishing thesis or a journal, do not put p-values. Give the odds ratio, relative risk, hazard ratio, risk difference with confidence intervals. So journal may insist on p-value, but what is really beneficial to the reader is the estimate with the confidence interval. So they have given you this confidence interval and we all said it's a medium confidence interval. Okay, so now we have seen two first questions. What are the first question? Was the study well done? Second is, what are the results? Third question is, can I use the results in Kashmir? What do you feel? Can I use it in my local population? And in the CAS questionnaire, they give 3 questions. The 3 questions, sorry if I'm blocking somebody, were the patients covered by the trial similar to the patients you work with? So you work with means your own setting, where you are sitting currently in the world. Are your patients similar to that in Kashmir? And how do they differ? So where was this? Are my patients similar? The study was done in New Zealand, US, UK. Now you may say that no, those are quite different from the people in Kashmir, right? And the compliance rate may be quite different. Maybe they are slightly different human beings who regularly take medicine. But generally human behavior is the same all over the world. So there is no magic population which is highly compliant. I don't know, maybe some Japanese people will be very robotic in their behavior. So the answer to that is to go back to your baseline characteristic table. Any pulmonologists or physicians here? Anybody who has had asthma here? You have? So what is your, I mean, I should not ask your age. Okay, you're a guy, I can ask your age. Does it generally fulfill this age group? And there are roughly 50% women in the study. So you're a man, so generally it seems to fulfill your criteria. Do you use asthma about 3 times a year? In the last 4 weeks, have you used salbutamol? Yeah, so it seems to fulfill your criteria. And how many puffs per week and all these things. So your job as a physician sitting in your own hospital is to decide, hey, my patients look similar to those patients. Does your genetics play a different? Because you're Indian, different from Americans, Australians? Are our genes different? 99.99% of human genome is conserved. In fact, from us to chimpanzee, it's only some 0.001% difference. So we can't claim that genetically we are different. I mean, there are people with genetic defects, but generally on the whole, genetic. Then you must ask, if genetically we are all the same, are there racial differences? We always quote some Ashkenazis, Jews cannot have this drug because they have a defect of this. But by and large, most people, it won't change. But we do know from biology, Africans in US, they respond differently to certain antihypertensives than others. So for this, you must ask the asthma expert, hey, are you aware of any racial differences in the response to, or any pharmacologists here? Are there racial differences in pharmacology of asthma response to salbutamol, steroid? So as far as we know, it's no. So other than some differences in age and gender, if there are no other differences, we can directly take the results of this to our population. You may disagree or agree, but you must make that call. Next question. Were all clinically important outcomes considered? Can anybody think of an outcome which was not considered? You got asthma, you're a pharmacologist. Did they miss out? Days of work missed. That will affect their quality of life, you think? Have they looked at quality of life? So I'm saying his particular question is, I'm really interested in how many days I missed work because that is a big deal to me. They didn't measure that, but they have measured quality of life, which we can argue reflects days missed, but it may not. So what is an important outcome for you was missed? Okay. Any other thing? So time to exacerbation. Hey, not only exacerbation, maybe I can get exacerbation much later on if I take this drug. So they have given you some picture. Now somebody can look at the Kaplan-Meier curve. Can somebody tell me the probability of an exacerbation at 200 days in albuterol? Let's see how many of you learned from what Dr. Kant's taught you. So the days are always on the x-axis. The probability of exacerbation is on the y. When it says 1 means at the beginning, nobody had exacerbation because at the beginning of the study, you are starting the study. As you get exacerbation, your curve comes down and down and down. Which is the worst performing curve? Albuterol or salbutamol. And the best are the other two. They seem to be reasonably the same. There doesn't seem to be too much difference between the first two curves. If you're doing cancer trials, they'll ask you median survival. The outcome is death. So as you die, you will start going down the curve. If somebody asks you median survival, you must see, hey, 100% was here, 50% is here. Where does the curve cut? And wherever the curve cuts, we'll say median survival was that many days. Here, 50% did not have exacerbation, so we can't say median time to exacerbation. When did at least 10% of people have exacerbation? This is 10%. That means they were zero exacerbation. When it came to 90 means 10% had exacerbation. So if we go this way, roughly 100 days in salbutamol. Somewhere here. Maybe it's 350 days. So your drug gives you about 250 days free of having an exacerbation. So this is one way of looking at the data in Kaplan-Meier. Or you can say from 200 days, you can go. At 200 days, roughly 80% of people in the salbutamol group had 20% had exacerbation. But at 200 days, only 90% of people in the other group had exacerbation. So there's about a 10% difference. 10% absolute difference in exacerbation. What will be the number needed to treat? 100 divided by 10, 10. So for every 10% people you treat, then you can also make out a difference. How long does it take for the drug to work? Does it work on day 1, day 2, day 3? How long does it take for the drug to work? Do the curves separate on day 1? When does the curve separate? You can see that up to here you may not statistically find much difference. Somewhere after only about day 80, day 90, the curves start to separate. Suppose the study was done only for 3 months. then you'll conclude the drug doesn't work. Correct. So that's why it's important to know when the outcome are measured at 25, 50, 60, 75 days. But so you must say when was the outcome measured. All these things you can get from a Kaplan-Meier curve. Now this is the asthma quality of life score, asthma control Q. These are the three curves. Was there any important difference in quality of life? These are the three graphs, and often they'll show you what are these lines. This is a point estimate, but that is the confidence interval for that point estimate. If the confidence intervals overlap, that means there's no difference. But here you can clearly see that this didn't seem to make much difference. Even though the exacerbation rate came down, people didn't seem to feel much different. So from the patient's perspective, we may say, hey, salbutamol costs 150 rupees. The steroid inhaler is $1,000. I'm not going to take it. There are so many ways to look at what will happen. What about adverse events? Can you all find this table? Table 3. You have to look at adverse events. What are SAE? And the non-pharmacology people tell, what is SAE? Serious adverse events. So then you can have treatment-related adverse events, sudden, unexpected, severe adverse events. So different classification systems are there for adverse events, and people will use these. So then you can pick up on that. So the most important thing was looking for severe adverse events. So if you give people steroids, people are often worried about getting lung infections. Some sore throat and all can just gargle and go away. So you can look for lower respiratory infection, 8% in the salbutamol group, 7.9 in the maintenance steroid group, and 6.3 in the as needed steroid plus salbutamol group. That doesn't seem to be too different. But you see, any adverse event is anything, cough, cold, fever, breathing, which most people will have something or the other. So very important to look at adverse events, correct? Second last question. Paisa vasool. Will you tell your poor patient who doesn't have much money, my friend, salbutamol inhaler is 160. It's actually only 160. Sometimes you can get cheaper Indian brands for 100 rupees. Budesonide formoterol is $400. Would you tell them to buy? How many of you, having seen all the evidence so far, will tell the patient to buy? Maybe I sort of slanted the discussion away from buy. Would you tell them to buy? No? That we know that they've given you all the numbers and all. So you have to actually make a decision about money. So let me try to put this for you. Salbutamol is 140. Budesonide formoterol costs roughly 400, and the combination one is about 550. Assume a patient uses one a month. You make some calculation on the back of your to decide about this. So I've given you the cost. What was the number needed to treat? For A versus B. NNT for the first two groups, 10.2 minus 9.3. Difference is only 1%. So 100 by 1 is roughly 100. So then if you multiply that, NNT for A versus B, these two, not A versus B. For these two, budesonide versus these two drugs, you roughly have to spend about 150 rupees more. So 111 into 260 into 12. So you will spend about 3 lakh rupees to prevent one exacerbation. Why? Because you have to give it for 12 months. Every day puff, and this is the cost of the puff. If you take it for the other one, 16, you all understood how we got 16? Now that is 16 for A versus C, that is salbutamol, this one versus this. So the difference. So 16 into 410 into 12. So actually you'll spend about 78,000 rupees to prevent one exacerbation. Should we spend? Severe exacerbation. What if I told you the hospitalization for severe asthma costs 1 lakh? Okay, then this is cheaper. What if it is only 5,000 rupees? Might as well let the guy have exacerbation. No need to prevent it. So going back to the question, one has to make some sort of calculation in your mind. Are the benefits worth the harm and cost? Even if the trial did not address it, you have to make some calculation. This I did the calculation for what is based in CMC Pharma. Suppose it is given free in government hospital. Any policy makers are here? From Assam policy makers sitting here. Shall Assam government keep this drug in your PHCs for free?
Because now NHM fund is there.
No, somebody has to pay. That means the taxpayer of Assam, should they pay for this? So it's a tough question. If you're a policy maker, everybody thinks it's free. But ultimately the taxpayer's money is going, your and my money is going to pay for this drug. Nothing free. So what did you say to the people from Kottakkal? Would you keep this in your place and give it free to everybody? Or the Tibetans keep this drug free in your place? Actually, when it comes to money, you have to make a tough choice. When somebody else is paying, it's easy. Yes, please buy and keep it. But when we have to pay for it and all our tax money, we have to make a decision. Have you heard of NICE? Not NICE, biscuit. National Institute of Clinical Excellence or something like that. It's a UK guidelines group. They will make a decision about every single drug for the UK because technically healthcare is free in UK. So they have a huge tax. Everybody has to pay a lot of tax. After that tax, drugs are free. So everybody is very worried because when you add a new drug to the NICE, tax going up. So they have to make a decision. Should we keep this drug freely available in the NHS? There's one nice place to read about guidelines because you can read about the RCT behind their evidence and they will an economic analysis to decide should this drug be available free of cost. Many new cancer chemotherapies are fantastic. Like, oh, miracle, guy was dying, he got up and jumped. But you have to spend 1 crore for that. No, we won't keep it in NHS. People, NHS useless. I mean, there'll be huge pharma pressure to get the media to say this and that. So there are a lot of things behind the decision. Okay, external validity means other than the study, were there some other things, and this people may not teach you. If the study was funded by the GlaxoSmithKline, is that a problem? Are they bad people? No, but if you read the article and they say, we developed the protocol, we paid the doctors to give us patients, we collected data, we analyzed the data, we wrote the paper, then it's a bit of a problem because they might have massaged some data, they might have done something. If the pharma company said we just gave the inhaler free, the study was developed by an academic center, data was collected by them, analyzed by them, then you're not so worried. So to make a decision, just because it was funded by pharma, you have to not throw it away, but you must make a decision about what was their role. So then you must think about this last question, efficacy versus efficiency. Just because, remember, randomized control trial, as Dr. Kant told us, is like a experiment of rats in a lab or plants in a field where you can give more manure here, less manure here. But human beings are not like that. The randomized control trial tries to mimic that because strict inclusion, exclusion criteria, every week phone call, correct? So what the NNT we got in real life may not be the NNT, NNT we got in RCT might be much different from what we get in real life. We may get slightly worse off benefits and we may get much more harm because we'll be including older fellows, alcoholics, smokers, and they'll be getting all the harm and may not be getting any of the benefit. So would you use it still then? Suppose your patient had pneumonia last month and you want to start steroid inhaler now, or maybe I may not give. So to have all these other thoughts, these are called external validity. There may be other considerations to think about. Evidence-based medicine has 3 parts. This is my last slide. What are those 3 parts to evidence-based medicine? Anybody? Patient preference, expertise, and what is the evidence? So now we have seen the evidence. Is it, as an asthma doctor or physician, I may have some expertise. Hey, I've given many patients this budesonide formoterol, it seems to work well. Then I'll tell the patient, see, in my experience, this works well, then he'll be very happy. What does patient's preference mean? How will patient know anything about what is salbutamol, what is budesonide? So very often patient's preference in India becomes cost. Doctor, how much is that? That's 500 rupees. I don't want. Well, that patient did not want. So sometimes what they mean is their value systems. Hey, I'm a vegetarian. This budesonide was made from non-veg product. I don't want. That is patient preference. But generally we mistake affordability for patient preference. I really want the transplant. Which renal transplant, which kidney failure patient doesn't want transplant? Everybody wants, but I can't afford that. So I don't want. So that is not a preference, that is financial decision. So it may be cost, availability. Okay, this not available in many pharmacies all over India. Even if I want, I can afford, I can't use it. Sensitivity. I don't think anybody in India will have too much difficulty. If I'm using salbutamol, I'm adding steroid, I may not be too worried about it. Culture, previous experience. Hey, my uncle and aunt use steroid, they're very happy. Family history, lifestyle, spiritual views. So we have so many reasons why patients may or may not want to take. I'm just trying to make it. So previously they said evidence-based medicine. Hey, the evidence shows relative risk of 0.4, you have to use it. Otherwise you're a fool. No. Now there's a that's physician's experience and the patient's views. The marriage of all three is evidence-based medicine. So now they say evidence-informed medicine. Because evidence can inform you. You or the policy may make totally different decisions. So I have told you this: research, clinical expertise, and the patient, marriage of all three. So there's no one decision which fits everything. If Ambani comes and asks Vignesh, what should I do? What will he give? He'll add the steroid. So this is very good for you. You can easily afford it. Some poor patient who can't afford, okay, either I can give him free, or I'll say, okay, let's just get the exacerbation and be done with it. It is far cheaper than adding on the steroid. I mean, you may say that's wrong medicine, unequitable medicine, bad boy, terrible guy, but that is reality. Okay, question.